Okay, good morning. We're here today to talk about pediatric nursing, and we're going to start talking about growth and development. In your book, it gives you a few of the terms that are important to know with growth and development. I encourage you to look at those. If you think about growth, I think we know what growth is: increase in physical size and structure. With development, it's a little bit more obscure. What you're looking at there is development psychosocially, cognitively, certainly in many different ways. Moral development is all there. Cephalocaudal, remember that when a child develops, and growth and development is especially easy to look at when you look at children, it happens from head to toe. And so the brain is going to start developing and it's going to move downward. Certainly maturation is also proximodistal, so that it starts from the inside and moves out. So those are principles we're going to talk about in a minute. Probably the two terms that I want you to look at the most are the critical period. Remember that every developmental skill or task, in fact, is going to have a period during which that skill can be attained. You could teach a 2-year-old perhaps how to play the piano, but it certainly may not happen because a 2-year-old's not mature enough, is not developed enough in order for that to happen. But there are critical periods that you don't want to miss in a child's development. And so think about when you're looking at a baby developing, there is a critical period during which they can bond with their significant others and their mothers. During the perhaps school-age child, that's a critical time when they're learning fine motor skills and handwriting and things like that. And then there's the developmental tasks, and I know we've talked a little bit about this when we've talked about the NCLEX questions. Think about what are the questions that people can ask about the developmental tasks of every phase, and certainly that's across the lifespan, from birth until older adult. But in the pediatric period, that's when you see a lot of developmental skills being attained. Every day is a little bit different. And so great questions could be asked about the pediatric client, and what task they're hitting, what skills they're attaining, and then what are the nursing implications of those. Things like appropriate toys, appropriate safety measures, appropriate play, all of those would be found in here. Certainly we know that every child develops a little bit differently as far as rates of development, but it's in a logical order. And so probably if you've seen children, you know some may walk well at 8 months of age, some may not walk well until they're 15 or 16 months of age. But the point here is that they develop certainly in a predictable pattern, but at different rates. And those rates can certainly be impacted by environment, by conditioning, by health, and by many other variables that we'll talk about. We know that babies and adolescents grow extremely fast, and that toddlerhood and school age is actually a slower period of growth. So let's start talking about some of the different theorists, and we're going to start with Sigmund Freud. Sigmund Freud, as you know, was into the psychosexual theory, and I know you spent a little time on this in your psychiatric unit. Think about how this impacts the pediatric population, so that in the very early age, early newborn, they're going through the oral stage. They receive their gratification orally. As we move on to toddlerhood, they become in the anal stage, where they receive their gratification from controlling their bowels and from developing all of those independent behaviors. As they move on, they go through the phallic and then certainly the latent stages. I don't know what kind of questions really could be asked about Sigmund Freud's theories, but I think it is important to think about things like when someone becomes fixated in a certain theory, or certainly what happens when there is, in fact, some psychosocial disturbance that causes someone to regress to another stage. Probably one you're more familiar with is Erik Erikson. Erik Erikson goes across the lifespan, and as I think I mentioned already, you're probably not going to be asked, this is a 20-year-old, what phase are they in? You're probably going to be asked to think about the nursing implications of those phases. So in infancy, you've got trust versus mistrust. Mothers or other significant others meet the baby's needs through feeding. And then in the 1 to 3 years of age, there's that period of autonomy versus shame and doubt. That's when babies become, certainly toddlers become independent, they become mobile, they learn the meaning of the word no. They become very, very set on developing some sort of an independent place in the world. And think about what would happen to a baby who then is immobilized. We're going to talk about traction in a moment. And think about a baby who's in traction, is not able to be mobile, is not able to move, and therefore may have a tough time meeting the tasks of that age. And as a nurse, you need to help them meet those tasks vicariously. So with nursing interventions, we talked a little bit already. You're going to monitor INO, maintain fluid restrictions, and diuretic therapy. You may, in fact, hyperventilate, as I said. You're going to monitor the child. And then if, in fact, something with hydrocephalus, we'll talk in a minute, they'll actually have a shunt placed in order to divert the CSF flow. All right, so let's start talking about the child with hydrocephalus. The child with hydrocephalus is kind of the classic increased intracranial pressure. But these kids tend to be a little bit more insidious than a trauma. And so it takes a little while for the pressure to build up. They show some other signs and symptoms. Again, they're going to have the behavior changes, the vomiting. They're going to have something called sunsetting eyes. Sunsetting eyes is when actually the irises are below the level of the eye so that you can see the whites of the eye all around. And the whites of the eye, again, looks like a setting sun, and that's from increased intracranial pressure. These children may have poor PO intake because they're feeling a little bit nauseous. They're going to have an enlarging size of the head. Remember, the cranial sutures are not ossified until the child's 2 to 3 years old, and so the head will continue to grow with a child with hydrocephalus. In one hand, that's a good thing, that the head can grow and the baby will not herniate. On the other hand, you may have seen babies with pretty significant head circumferences because of this growth. Let's see, they also may, in fact, have papilledema. When you look at their retinas through the ophthalmoscope, you can actually see papilledema, edema of the optic disc. All right, now there's two kinds of hydrocephalus. There's communicating and non-communicating. In non-communicating, it really means it's just obstructed. So if you think about it, there's the little circulation of how the CSF goes through the ventricles. It goes through there in order to lubricate and also to bring some of the white blood cell products. When it's obstructed, they're going to have a non-communicating hydrocephalus. So they keep producing it, but it's not allowed to go out. They also call that a poor outflow hydrocephalus. Then there's also when a child makes too much CSF, and that's considered a communicating, or when it's not being reabsorbed appropriately. So all of those three reasons leads to what is commonly called water on the brain, or too much water in the ventricles. So how we manage that is they'll try it conservatively for a very short period of time, but most children with hydrocephalus need to be shunted. And they're shunted with either something called a ventriculoperitoneal shunt, or a VP shunt, or they'll have the distal end will be in the jugular vein, so it'll be a VJ shunt, or they'll actually call it a VA shunt, where it goes right into the right atria. And all they're doing is taking the CSF and diverting it out of the child's brain into the circulating blood volume. There it's absorbed, and there it can be excreted. You can imagine that these shunts may in fact become infected. They can become obstructed. And certainly as the children grow, the shunts require revisions, especially the VP shunt, because you think about the distance between the ventricles and the peritoneal cavity. And so as the VP shunts are grown out of, they're going to do what's called a shunt revision. They'll go in and they'll elongate the shunt. Shunts can actually work for a lifetime, or they sometimes are known to have frequent infections and obstructions, and it's not really known why some are more successful than others. When the catheter is threaded in, they're usually threaded such that they have a little bulb that is placed usually right behind the ear that's called a pump, and they actually have a double bulb so that the parents will be taught to pump it. And that pumping action tries to prevent obstruction of the tube, and so it actually allows for some circulation of the fluid so that it isn't too stagnant. Okay, so care of the child, you're going to keep them off their operative side. You want to elevate the head of the bed. Anytime you think of anything that could cause cerebral edema, you want to elevate the head of the bed. You want to assess their airway. You're going to watch for signs of ICP. And then certainly you're going to want to watch that child long term. You're going to watch that child developmentally. Okay, the second neurological issue is spina bifida, or myelodysplasia. And remember what happens in spina bifida. It's failure of closure during embryological development around the vertebral arches. And so all mylos, or all spina bifidas, are in fact going to be a result of this failure to close. Now, some are actually rather benign, and some can be pretty significant. And we'll talk about all three of those. The cause is unknown, but again, an NCLEX question that you've probably heard a lot about is that folic acid taken in appropriate amount during childbearing years can prevent neural tube defects. And so that's one of the questions I'm sure you've seen before. Some important things about doing a tonsillectomy and the nursing care of patients with tonsillectomies. Patients will generally come back from the operating room with an ice collar, and again, that's to decrease the swelling. Some kids tolerate it, some kids do not. Some kids just do not tolerate that ice collar. So again, analgesia is an important thing. One of the measures that they use to assess whether or not a child's ready to be discharged is whether or not the child can drink, and sometimes it takes quite a lot of wheeling and dealing to get the kids to drink postoperatively so that they can in fact go home. You want to make sure that you don't use any red juices, because again that would be difficult to differentiate from bloody drainage. I also don't particularly like blue popsicles because they make you look cyanotic, but anyway, the idea is that you want to make sure that they drink something that in fact does not look like blood. Remember that a sign and symptom of potential hemorrhage, or a potential sign and symptom of hemorrhage, is frequent swallowing. So the kids will actually be swallowing a lot, and you'll want to assess for that. After a TNA, there is some bleeding to be expected, and it's usually dried, and it's usually they'll spit it out or they'll swallow it. If they have frank red blood drainage, then it's probably the sign that they have sloughed a scar. And that usually, the scab usually doesn't get sloughed for about 5 days. And so you'll hear about patients that go home from the hospital and 4 days after, 5 days after their surgery will come in for a bleed. And that's related to the fact that their scar has sloughed off prior to it actually being totally healed. Let's see, so you want to make sure that you position them on their side. You want to think about the fluids that you want to give. Chewing gum is thought to decrease the pain because it increases the saliva and allows for more swallowing. And certainly, again, the signs and symptoms of hemorrhage are something that you're going to want to watch for. Croup is actually also called acute spasmodic laryngitis, and croup you all have heard about when you think of the croupy cough. The way I want you to differentiate and think about croup from LTB, which is the next one, is that croup is acute. It's sudden onset. So the typical scenario is a baby wakes up in the middle of the night, has a lot of that hoarse inspiratory stridor and a very barky cough. And that's kind of one of the classic signs of croup, is that barky cough. They may be afebrile, and they appear to be having trouble breathing. And so what we counsel parents to do is take the child into the bathroom, turn on the shower as hard as you can, close the door, and allow the bathroom to become steamy. So at that point, what you're getting is humidified air. That tends to stimulate some of the movement of the secretions, decreases some of the swelling so that the child can breathe. And more often than not, the kids end up vomiting, especially lots of mucus, after they have gone through this acute attack. There certainly have been some causative factors related to child has a mild viral infection that then all of a sudden they go into this acute respiratory distress with the croupy cough. LTB is just a little bit different. Again, it's a viral infection around the same spot. It's the larynx, and it can go down into the trachea and the bronchi. But what's different about this is that it's kind of got an insidious onset. So the symptoms are getting progressively worse and worse. And so the child will just get more and more uncomfortable till the point is that they actually still have some sort of airway obstruction and cough. Again, the treatment is the same. When the patients get to that point, go into the bathroom, turn on the shower, close the door, and allow a lot of that mucus to come up and be vomited up. In the hospital, they'll actually treat with things like racemic epinephrine. Remember, epinephrine opens up the airways, And so it's a sympathetic stimulant, and it will, or a sympathomimetic that opens up the airways. They may use antibiotics only if it's thought to have some bacterial component, and they may use steroids to decrease the size of the airways. Yes?
Do they start off with like an albuterol adjuvant treatment first and then go to racemic epinephrine, or will they just go right for the?
It depends on the degree of respiratory distress. They're very much more cautious in using albuterol in children than they used to be because they try and reserve the albuterol for bronchospasm. And this is actually not a bronchospasm. It's stuff inside, so that they really don't want to. There's no bronchoconstriction to relieve. It's more the epi just opens the airway a little bit so that it can expectorate or swallow some of that mucus. Good question. Okay, so with LTB, you're going to have, and in case coryza is copious amounts of nasal drainage. And they have a lot of nasal drainage. They're going to have inspiratory stridor, again, that barking cough. They're going to be tachypneic and tachycardic. And they may have a difficult time taking PO, and some of that's just because of the airway obstruction. I'm sure we've all had a cold when it's hard for us to drink because your nose is so stuffed up. Epiglottitis, on the other hand, is something that's considered, bless you, a medical emergency. Epiglottitis, if you think about where the epiglottis is, it lies right over the tracheal opening. And it ends up looking almost like a dangling gland. What ends up happening is the epiglottis becomes large and inflamed and red. And if, in fact, it's at all irritated, it can close off the trachea. And so epiglottitis actually used to be a very common, life-threatening disorder in children that we hear so much less about because the chief agent for epiglottitis used to be Haemophilus influenza. And now we have the Hib vaccine, so we see less and less people with epiglottitis.